Welcome, and thank you for joining us on this Giving Tuesday 2025. I'm Kapila Viges. I am the Chief Executive Officer of MPN Research Foundation. And on this day, we wanted to express our gratitude for you, our donors, and your contributions to advancing our research mission, which, as many of you know, is to fund novel research in pursuit of new treatments and eventually one day cures for myeloproliferative neoplasms. Your trust in us is incredibly humbling, and it is honestly what motivates our entire team to continue this ambitious mission, disrupting the status quo for diagnosing and treating ET, PV, and MF, while we're still going after cutting edge research in search of cures for these blood cancers. So today we want to share our appreciation for your trust in us and give you something back. We want to share with you the impact and outcomes that MPN Research Foundation has achieved with your financial support in our past 25 years and the progress that we are ambitiously pursuing that is propelling our foundation forward into the future. I am really fortunate to have both co-chairmen of our board of directors, Barbara Van Heusen and Brandon Getzman, here to share how our past will lead us through to the next 25 years of progress. And as a special featured presentation, you'll get a peek into the real-time innovation that we are funding today. You'll hear from Dr. Shannon Elf, Associate Professor at the Huntsman Cancer Center, on an exciting CRISPR project that she is co-leading. We have learned so much about gene editing breakthroughs in other disease areas, as have many of you as donors and have come to us asking, and we started asking, what is it that MPN Research Foundation can do to move gene editing forward in myeloid cancers? Dr. Elf and her colleagues were ready to get to work and answer that call, so we're really excited to hear from her today. But first, before we begin, a small housekeeping item. We absolutely want you all to engage with us today during all the presentations and discussions. Please use the chat feature that we have available in Zoom to share your comments, share where you are joining us from, any questions or ideas that come to mind. We love how engaged and empowered you all are. You always bring the most insightful and thoughtful questions and comments. And so we encourage you to continue to do that throughout our talk today. But we do have a pretty packed agenda, so we likely won't be able to address all the questions live. We will definitely follow up with all of you afterwards to address your comments, your questions, and be sure to share further information about our research programs and any resources that you might be seeking. So please do use the chat feature and continue to engage with us throughout the hour today. But for today's agenda, just to quickly review, we'll start with our past. Barbara Van Heusen, our longstanding chairman of the board and now co-chairman, will talk about how far we've come. And next, we'll dive into Dr. Elf and her team's innovative work that you all are supporting with your contributions to leverage the CRISPR technology to selectively kill MPN stem cells. And then we'll hear from Brandon Getzman, also co-chairman of the board, with a look at what's next in 2026 and beyond. And then I'll come back and close with a Giving Tuesday challenge for you all extended by our board of directors. So first up, I am delighted to introduce a co-chair of our board and my friend, Barbara Van Heusen. Barbara?
Thank you all. I'm really delighted to be here. My job is to talk about, it says right here, talk about the past. And as Kapila said, we're celebrating our 25th anniversary at the MPN Research Foundation, which means I have to talk about 25 years worth of progress in 10 minutes. But unfortunately, I really have to start a little bit further back than that. And I think Kapila, you could, or I'd like to have the slide up that shows the progress, because I'm not going to go bullet by bullet through the slide. I'm going to, there we go. I'm going to tell a story. And the story starts actually in 1996, when my good friend and work colleague Bob Rosen was diagnosed with PV. And being the curious guy that he was and sort of insistent person he was, his first question to his doctor was, polycythemia vera, what is that? And his next question was, how did I get it? And then who's doing the work on this disease? What do we know about it? So he started immediately asking questions, which was kind of what he did, and discovered pretty quickly that there were very few active researchers in the MPD field, though in those days they were called myeloproliferative disorders. There were no drug companies involved in these diseases. And when he first went to ASH, the annual hematology convention, he was dismayed to find out that nobody was using the words MPD or polycythemia vera at all. And it's sort of important to note that ASH this year in 2025 starts in a few days, and the difference between Bob's first ASH meeting and what will be happening this year could not be more stupendous. So Bob found two and then three other patients, and the four of them together decided doing nothing was not acceptable. They were going to do something. And so in 1999, the then MPD Research Foundation was founded. And the founding board members began the work of the foundation by chipping in their own money and starting to fund research. The first grant was given by the foundation in 2001 to a researcher named Joe Prakal, who is happily still one of the leading lights in the MPN scientific field. And in 2000 and 2005, the first years of uh, the foundation gave a number of grants to a growing number of researchers. The more people we knew, the more money we gave away. And it was about that time that Bob asked me if I would spend some time helping get the foundation organized. And I said yes, silly me. And coincidentally, and this has happened, I can't tell you how many times with people who have become involved with the foundation. I discovered that one of my aunts, a favorite aunt of mine who is known in the family as Clotter. She got blood clots every time she had a baby, and I had a lot of cousins, so she had a lot of babies and a lot of blood clots. She had essential thrombocythemia, and that's what happened in the first 5 years of the foundation. The more questions we asked, the more people we found who were being diagnosed with these diseases, who had nowhere to turn, and who wanted to participate in their own prognosis. So we started giving grants in 2000 to 2005 with money donated by the original board members and a growing list of patients who wanted to, as Bob and the board members did, wanted to do something. We got to know more and more researchers, and we began to work in addition with the Leukemia and Lymphoma Society, which was way bigger than us, but was not focused on the MPDs. Uh, and so we started to do what we felt was good work, but it was groundwork. It was starting from a scientific environment in which no one knew how to spell, for example, polycythemia vera, but patients really drove this work. And then in 2005, it was like a thunderclap. Everything changed. There had been in the background a number of researchers who were following up on the progress made by the Human Genome Project, were starting to look into the genetic underpinnings of these blood disorders. And in 2005, there were several almost simultaneous papers discovering or documenting the fact that the majority of myeloproliferative disorders, MPDs, were related to a single point mutation in a gene called JAK2. And Bob, at this point, knew quite a few scientists. He was getting to know as many as he could. And he asked Ron Hoffman, who happened to be a neighbor of his. Ron was a professor at the University of Illinois, hematologist at that time. He said, "Is this Jack 2 thing going to be a big deal?" And Ron Hoffman said, and this is sort of an apocryphal story, he said, "This will change everything." And in fact, it did. The MPDs went from being the group of diseases that nobody really understood to being one of the hottest things in hematology. And, we did not write those papers. But by the time they were published, we knew the people who were going to pick up the flag and run with it. So we, the foundation, which at that point was a small but growing group of volunteers, we pivoted to focus on the Jack mutation and to fund the kind of work that would bring the this discovery, which is hugely important, to from the laboratory to the bedside of patients. And so we got together with three leading researchers at Harvard, Mayo, and the University of Illinois, and funded a 3-year project, which we called the NPD Research Alliance. And this small foundation, the NPD Research Foundation at the time, invested with the help of patients like the people who are on the call tonight. We funded $2 to $3 million of research, which both increased the gene discovery, it built tissue banks, and did the preclinical testing, which is required to take a scientific discovery from a test tube to something that can be actually used by patients. It was a huge effort for a really small group. And we're happy to say that after 3 years of funding, the MPD landscape was completely different. For one thing, it had changed its name. The World Health Organization renamed the myeloproliferative disorders, renamed them as myeloproliferative neoplasms, which means cancer, and which opened up funding from the government, from the National Cancer Institute. After 3 years of funding these three researchers, we realized that we had done that job and we could pivot to something else. There were companies engaged, multiple companies at this point, in developing MPD drugs. There were drugs in the pipeline, and so we began doing what I think we've done particularly well over our first 25 years, which is pivot, which is change direction, so that we weren't just funding research to fund research, but we were funding research that wasn't going to get done without our help. So we started focusing in 2009 on grants to new investigators. We used to call them young investigators, but some of them actually weren't even young. And we started giving grants for genomic data research. And, one of Bob's favorite stories was about the impact of the Human Genome Project on our work and on the results that we've had. And that's it. We all felt, I think, some convergence of scientific activities that, once again, we weren't driving, but we were taking advantage of. So we've funded some new investigators. Some of those new investigators now, almost 20 years later, are leaders in the field. And we gave money to people who were, as I said, doing genomic research. In 2011, coincidentally, but partly on account of the work we had done, we had started in the MPD initiative. The first drug, Jakafi, was approved by the FDA for polycythemia, for I think it was for myelofibrosis, Later, it was also approved for polycythemia vera, and there were other companies in the horse race to develop drugs for MPDs as well. 2011, we said, okay, time to pivot again. We started an annual program called the MPD Roundtable or MPN Roundtable, a meeting where we bring leaders of the biopharma industry together with academic researchers and patients and ask the most important question, I think, that can be asked in any year, which is what's next? What's not being done? Where shall we aim this growing power of patients who want to have some impact over their own disease progression? So we conduct that meeting every year, the MPN roundtable. And we kept giving grants where the need was the most. And in 2011, we funded a researcher named Robert Kralovics, who had been a previous fundee of ours. And in 2013, his research, this is a 2-year grant we gave him for $150,000 each year. He discovered the missing puzzle piece in the MPN universe. As most of you know, the JAK2 mutation accounts for roughly 2/3 of MPN patients. The mutation discovered by Robert Kralovics with our grant, I can't tell you how incredibly proud we were and still are, accounts for most of the rest of the other third. There are other mutations, the MIPL mutation, which we're now focusing on, and a few cases of triple negative MPNs. But the Robert Kralovics grant was truly a home run for a small outfit like us. So since then, we continued every year to hold a roundtable looking for unmet need. We have continued to learn and to grow both in the people that participate in our research and the people that fund our research. And we have attempted to use the lessons that we learned in the first 20 odd years, which is that patients can have an impact and that we have to remain flexible. We have to be that word pivot is it's a key concept with us because as soon as we feel that we're making some progress in one area, we're looking for the next area to fund. So in conclusion, even though compared to 25 years ago or more than that when Bob was diagnosed, MPNs are now we're at the forefront of hematology and scientific and medical research. And there are, as you are probably aware, multiple drugs approved and in the pipeline. But the conclusion of my story is as much as we are grateful for all of your participation and contribution, we are not done. We're not done, but we are resolved. We lost Bob in 2018, and we've lost too many people that we have come to love. And so the past informs the future, but our future is bright, and we are hungry for the next successes down the line. So that's my message on the past, and I look forward to any questions you folks may have.
Thank you, Barbara. I think it is so important for us to know where we've come from to help chart the course for where we're going. So thank you for that. And next up is our featured presentation, the work that is happening in real time today. And so I am so grateful for her time. I am honored to introduce Dr. Shannon Elf, Associate Professor at the Huntsman Cancer Institute at the University of Utah. Dr. Elf is co-leading this work to leverage CRISPR technology to selectively kill MPN stem cells, along with her colleagues at the University of Utah, as well as Utah State. So Dr. Elf, please take the floor.
Thank you so much. It's really my honor to be here. I really am so grateful to get to share this work with you guys and hear from you about how you might see this helping you in the future. And I do just want to say that I moved my lab to the University of Utah from the University of Chicago. And part of what drew me here is that Joe Percal is actually here at the University of Utah, the first person to get an MPNRF grant. And so it's really like an honor to work with him. And um, I'm so glad that you guys supported Joe because he's really a leader in the field. Okay, so today I'm going to talk. Let's see if this slide control works. Okay, there we go. Um, it's a little bit delayed. Okay, so oh my gosh. Today, I'm going to talk to you guys about literally a project that's happening in real time that is a collaboration between my lab, Yang Lu's lab, who's also at the University of Utah. He's a biochemist, and Ryan Jackson's lab, who's also a biochemist at Utah State University. Um, and this is our beautiful cancer center here in this picture, literally like right in the foothills of the mountains. Um, so, um, so just to give you a little bit of background on what CRISPR-Cas systems are, I'm sure like these are kind of in the news now, and you see them, you see kind of CRISPR and hear about CRISPR regularly. But I just want to quickly walk through how this system works. And so CRISPR-Cas is basically like a pair of molecular scissors. And the way that this system works is um, it can search for a specific spot in the DNA and then cut it. And we frequently use this technology in the lab, like as a tool to edit the genome in ways that allow us to study the function of different genes. And so the way that this works is that you deliver a short piece of RNA, which is this sgRNA here, which stands for single guide RNA, to the cell. And that short piece of RNA goes into the cell and it can locate basically like a GPS. It can tell, it can locate the target DNA. So it can locate the DNA that you want to cut with the scissors. And then the scissors are actually the enzyme Cas9. And so Cas9 is guided to where it needs to actually exert its scissor function by that sgRNA. And so, what are the outcomes of this? So, as I said, in my world, we tend to use this system in the lab as a tool. And so there are several outcomes, many more beyond what are on this slide, but this is sort of like foundationally what CRISPR has historically been used for in the lab. And so, what are these outcomes? So, the first outcome of using one of those small pieces of RNA to tell Cas9, cut the DNA here, is that you can introduce a mutation into the DNA. So, basically, what happens is the Cas9 will cut the DNA, and the DNA naturally has repair mechanisms in the cell. And so, it will try to repair itself. And what can happen when it tries to repair itself is that it introduces mutations during that process, like by accident, essentially. But what we can do if we want to introduce a mutation into a cell, like a MPL mutation or a CalR mutation or a JAK2 mutation, is we can design the guide RNA so it will introduce those specific mutations. And so we use this a lot as a tool to introduce these mutations into cells so we can study those mutations in the lab. And probably the most common use of CRISPR in the lab is to delete genes or knock out genes. You might hear that phrase gene knockout. And when this happens, the DNA will repair, but it will like not incorporate whatever you designed your guide against. And so it will repair, and that piece of DNA that you wanted to get rid of gets kicked out. And so now you have a genome that doesn't have that gene of interest in it. And we use this a lot in the lab to study like what a gene is doing. So if you get rid of it, you can study what happens when you don't have that gene anymore. So we do this a lot with genes that we think are involved in disease initiation or disease progression, to see what happens if we get rid of those genes. And then lastly, you can end up with an insertion of DNA. So instead of that piece getting kicked out, you can have a piece of the genome inserted somewhere else. And so these are kind of the three basic outcomes of the CRISPR-Cas9 system. And so beyond like using this as a tool in the lab, this has now become used in therapy. And so you probably have heard that CRISPR-Cas9 therapy to treat sickle cell disease was FDA approved in 2023. This was the first FDA approved use of CRISPR-Cas9 in therapy. And that was really huge. And has led to like a number of efforts to use CRISPR-Cas in other diseases to correct mutations, to reintroduce genes that are missing, to get rid of genes that are driving disease and driving cancer. And so MPN has not been left out of these efforts. There have been many efforts made, including some funded by MPNRF, to apply CRISPR-Cas9 to MPN therapy. And the two that really pioneered these efforts were those that were seeking to correct the JAK2 V617F mutation using CRISPR-Cas9. And so here, what the goal is to, instead of introducing a mutation, you're correcting a mutation back to its original sequence. So in this case, you would correct the F back to a V. So instead of JAK2 V617F, you just have regular JAK2 again. The problem is that CRISPR-Cas9 tends to have low editing efficiency, and this means that not enough cells are actually getting that corrected edit in order to like really have an effect. And then the other problem with this is that to correct a mutation like this in cells or reverse a mutation, you need a lot of cellular machinery. And this is like a very complicated process. And so a lot can go wrong. And so ideally, like we want to just really be able to kill the mutant cell, which is simpler in theory than actually correcting a mutation back to the native protein. And so this is kind of where our project comes in. And so like we really have been interested in this concept of using CRISPR as therapy, but recognize some of the challenges that are inherent with CRISPR-Cas9. And so my collaborator and co-PI on this project, Yang Liu, and my other co-PI, Ryan Jackson, had been working on this new system called CRISPR-Cas12a2. And they had been working on it in the context of just sort of biochemically how this system works. It's a new Cas enzyme, so they were working on kind of characterizing it. And so they came to me and were interested in applying this as MPN therapy. And so how is this different than CRISPR-Cas9? So Cas12a2, instead of binding to DNA like Cas9, it actually binds to RNA. And so you deliver a guide RNA that also binds to RNA and guides the Cas12a2 to bind to RNA. So that's the main difference, is that it's an RNA binding protein rather than a DNA binding protein. And then once that it binds to the RNA, it also has that scissor function like Cas9, but it cuts both RNA and DNA in this context. And the result of that is actually, rather than making these cuts and inducing DNA repair that can introduce a mutation or a deletion or whatever, it actually leads to complete shredding of the genome, and this kills the cell. And so it's a really remarkable technology because you can design these small guide RNAs to anything you want in the genome that, and this allows specificity. So you can design a guide RNA to like a MPL515L mutation, and it will go only to cells that have the MPL515L mutation, shred their genome and kill them, and it will leave everybody else alone. And so just to demonstrate how specific this technology is, what I'm showing you here, these are not MPN cells. These are lung cancer cells. And this is data generated in Yang Lu's lab. And so what they did was they took lung cancer cells that have a mutation called KRAS, in a gene called KRAS. And if you look at just the top left, I don't know if you can see my mouse, but the top left quadrant here, these are lung cancer cells that have a KRAS mutation and are being delivered what we call a non-targeting guide RNA. So this is a control guide RNA that doesn't target any part of the human genome. And we use this control just to show that even though Cas12a2 is in there, nothing's happening because you don't have the guide RNA to tell it where to go. So we're not getting any cell death. And the green are the cells. So you can see there's a lot of cells there. Now, in contrast, if you look at the top right quadrant, you'll see that these are, again, the same mutant KRAS lung cancer cells. And now they're being given a mutant KRAS guide RNA. And so, and you see many fewer cells here, right? So a lot less green in this quadrant. And that's reflective of the fact that most of these cells, like 90% plus of these cells, have been killed by the mutant KRAS guide RNA. And to show you how specific this is, if you look at the bottom two pictures, these are cells that don't have a KRAS mutation. They have wild type or regular KRAS gene in them. And there's no killing happening at all in these cells when we deliver either a non-targeting guide or a mutant KRAS guide. And so, and KRAS, like JAK2 and like MPL, is what we call a point mutation. It's just one DNA base pair change. And so that's how specific these guides are, that it can differentiate between one DNA base pair and another and kill the ones that have the mutant base pair and leave the other ones alone. So it's a really remarkably specific technology. And so how do we leverage this system for MPN therapy? So the problem with current MPN therapies and why we sort of decided to embark on this project is that, as all of you probably know, the only current curative therapy for MPNs is bone marrow transplantation. And none of the current targeted therapies, including ruxolitinib, kills the mutant stem cell. And if you can't kill the mutant stem cell, you're always going to have a pool of cells that can kind of give rise to the disease, even if you kill all the cells that are circulating in your blood. And the other problem is that most of these targeted therapies are also damaging your healthy blood cells. And so this is what causes a lot of your side effects. And these, as you well know, if you have an MPN, can significantly diminish your quality of life. And so one of our biggest goals in this field as researchers is to develop better therapies that overcome these challenges. And so how does CRISPR-Cas12a2 overcome these? So first of all, it has the potential to be a curative therapy because it can target and kill mutant MPN stem cells. And that will cut off the disease source. So it cuts off that pool of cells that can repopulate the disease. It also, as I showed you, is highly selective. So it only kills the mutant cells. And it will spare all of your healthy blood cells. So you won't experience all the kind of pancytopenia that you experience on, for example, ruxolitinib. You, in theory, should have many, many fewer side effects due to the specificity of this therapy. And it's easily adaptable. So we can actually apply this technology really to any mutation. And we have some early data showing that we're able to do this for MPL, we're able to do this for CALR as well as JAK2. And so, it's not a whole, we don't have to start from scratch every time we want to target a new mutation. So we can just use the existing technology, design a guide to whatever the mutation is, and the whole thing is already set up, which is really nice. And so, what are our goals for this project? So, the first goal we have is to use CRISPR-Cas12a2 to kill hematopoietic stem cells that we get from healthy donors, and we overexpress the MPN mutations in them. And the reason we do it this way is because we want a cell that only has the MPN driver mutation, so just JAK2, just MPL, or just CALR, to see like if we just have that driver mutation, at baseline, can we design a guide against that and kill the cell? And then from there, we can go and get a little bit more complicated. So our second goal is to then once we're able to establish proof of principle using the first system, to take stem cells from MPN patient blood and bone marrow that have additional mutations. So they don't only have a JAK2 mutation or a MPL mutation or a CALR mutation, they might also have ASXL1 or TET2 or something. And so is it just as effective if you have additional mutations? And so that's what our goal is to find out with the second question. And then the last question is, can we deliver this system to an organism like a mouse? And does it actually either ameliorate disease or cure the disease? And so this is a long-term goal. We've started on the first two. We haven't started on the last one yet. But obviously the last goal is really our preclinical goal to see like, would this one day be possible to put into people? So if we can put it into a mouse, there's a good chance we could hopefully put it into a person. And so I just want to thank and draw your attention to this is a big team effort. So my co-PIs are Yang Lu, like I said, and Ryan Jackson. We're also working with Sri Tantravahi, who is an MPN clinician here at the University of Utah, as well as Ned Weinshanker, who many of you may know. He is an MPN patient himself, and he's helping us with kind of commercial development opportunities and patents and things for this work. So thank you so much, and please feel free to reach out with any questions you might have or leave them in the chat. But thank you. It's such a pleasure to talk to you all today.
Thank you, Shannon. Such exciting work. And like you said, it's both real time, and MPNs aren't being left behind from this exciting innovation in gene editing. And so it may be a longer road ahead, but so promising. And thank you for making it relatable and accessible. And as Shannon said, for anybody who has questions about this, please either put them in the chat or reach out to us, and we'll be happy to follow up and get them answered for you. But wanted again you all to see exactly the types of things that your funding, your contributions are able to help us achieve in real time. And with that, as far as we have come with your help, we all know that our work is not yet done until every MPN patient is cured, and we prevent future MPNs. Maybe gene editing is part of that solution, but we're not there yet. So introducing Barbara's partner in crime and fellow co-chair of our board, Brandon Getzman, will share a look of what's ahead for MPNs. Brandon?
Thanks, Kapila, and thanks, Dr. Elf, for that exciting update on your cutting edge research. It's really, really exciting to see your progression on that CRISPR technology and its application to MPN. So thank you for that. We look forward to seeing that continue on and hopefully make its way into the clinic someday. So I'm Brandon Getzman. I'm co-chair of the MPN Research Foundation. I've been a board member of the foundation for about 9 years now, and I wanted to spend a few minutes looking forward to the foundation's research funding plans, which are research focused. Funding is our core mission, and don't see that changing at any point in the near future. We Our primary funding mechanism going back, and as Barbara mentioned, to earlier days in the foundation has been our MPN Challenge Grant program. And if the team could move the slide forward to the summary on the MPN Challenge Grant, I would appreciate it. Thank you. The MPN Challenge Grant program is really where we have invested the lion's share of our $21 million of research commitments over the foundation's history. I would really describe it as our bread and butter research funding mechanism for finding the best and most innovative opportunities to move MPN science forward. Over the last several grant cycles. We often do these on 2-year cycles. Our grants have typically consisted of $200,000 grant amounts funded over 2 years, so $100,000 per year. And we monitor the progress of those grants over the 2-year life cycle to ensure sufficient progress is being made. In 2024, our most recent grant, MPN Challenge Grant process, I wanted to share with you kind of the amount of interest we received, from researchers around the globe. We received 45 eligible grant proposals through that RFP process. We peer reviewed 18 out of 45 of those proposals, and we ultimately provided funding for 6 out of the original 45 eligible grants, so about $1.2 million in research commitments. And I mentioned, the peer review process, and I think that that's worth highlighting in that we assemble, and it is really a Herculean effort on behalf of the MPN Research Foundation team, assembling some of the top clinicians and researchers in the field to help us vet all of these proposals and rank them in terms of their quality and potential for patient impact in terms of moving the field forward and potentially clinical impact through advancements in therapeutics and other opportunities. We also recently, in a few of our past MPN Challenge Grant cycles, incorporated patient peer review as well. So patients are involved in helping qualify these ranks or these grants and figuring out where we should be deploying the foundation's resources most effectively. In 2026, we're on the verge of launching our newest MPN Challenge Grant process. We all know that inflation has had an impact on all things in our economy. That includes MPN research funding. So we're increasing our grant size from $200,000 to $250,000 over the 2 years in order to continue to sustain quality research and support these research teams that we back. And as Barbara had mentioned, we consistently encourage new MPN research investigators to apply in hopes that these investigators will dedicate their career to MPN research and clinical impact for MPN patients. And we've seen that occur with a number of the investigators that the foundation has funded over the years, and that enhances, the collective power of the MPN ecosystem by including more brain power focused on moving MPN research forward. For this 2026 MPN Challenge Grant process, we're focusing on two key areas. We all know that artificial intelligence and machine learning are things that are disrupting industries, across the economy, leading to potentially higher efficiencies and productivity gains. We believe that AI and machine learning can also help MPN patients. And so we are requesting grants that are going to focus on artificial intelligence and machine learning applicable to a number of facets of MPN research. And this includes MPN disease biology and discovery, MPN patient diagnosis and imaging, MPN patient risk predictions and prognostics, and MPN patient therapeutic applications. So we are very excited about the potential of AI and machine learning and its applicability to MPNs, and we want to be at the forefront of driving research forward that can harness the power of AI and machine learning and deploy it to MPN science. The second key focus area for our 2026 challenge grant process is focusing on the MPL mutation. We've seen a lot of progress being made on targeting JAK2 and calreticulin in particular. And we believe it's time to focus on MPL because it's been under-invested in historically, and the patient population with the MPL mutation is at least 3% of the total MPN population. But we think that there is a real opportunity to make a difference in better understanding MPL, and hopefully that will lead to specific therapeutics that could target MPL in much the same way that we're seeing therapeutics that can target JAK2 and calreticulin. So that is the second kind of key focus area for our MPN Challenge Grant process that we're excited about. We're going to begin accepting research proposals in early 2026. We currently invest somewhere between $1 million and $1.5 million per year on this key funding initiative. But with increased donations from our supporters, we can definitely do more. For a comparison, our 2024 funding cycle, I mentioned we funded 6 grants, but we had 45 grant proposals that were qualified. That means we only could fund 13% of the grants that we received. And that's, it really is splitting hairs when you are comparing, the 6th grant versus the 7th grant versus the 8th grant. And if we had additional funding, we could do more. We could fund a larger percentage of the research proposals that we receive. So we're hopeful to do that in 2026 with your continued support. Next slide, please. I want to talk about another very exciting initiative, which is our progression registry. And Barbara mentioned, the foundation's ability to pivot and need to pivot over time. And while we continue to be consistent with our MPN Challenge Grant funding initiative, one of the key things that we have been focusing on over the last several years is a pivot to driving a database, I should say, that can help move MPN research forward for years and decades to come. And we just launched the MPN Progression Registry in October. It's a first of its kind direct-to-patient observational registry. We're targeting enrollment of over 5,000 adults living with an MPN. So that includes ET, PV, MF, and secondary AML patients that previously had an MPN. It's designed to track patients for the next 5+ years and collect both retrospective and prospective data on their MPN journey. It integrates electronic health record data and patient-reported outcome data to allow researchers to study how MPNs evolve over time, hence the progression name in the name of the registry. Our goal is to focus on identifying and characterizing risk factors, progression pathways, and defining clinically meaningful progression endpoints. And we think we can utilize this database as a way to drive clinical research, care optimization, and have an impact potentially on regulatory endpoints and regulatory science. We launched this a little over a month ago. We already have 350 patients enrolled towards that 5,000 target. If you're living in the United States with an MPN, we would invite you to enroll and assist in this research effort. And the financial commitments of our supporters will help our foundation continue to grow this registry to become the most valuable MPN patient database available to help drive MPN research forward for the years and decades to come. So we're very excited about having reached the milestone of launching this new project. I will turn it back to our CEO, Kapila.
Yes. Thank you, Brandon. Hopefully I'm there. You can see me. Thank you for that, Brandon. I think, again, seeing how far we've come, really charting a course to where we're headed, is incredibly important for us. And we're excited about where we're going on this journey, not only with our 2026 MPN challenge, but with the progression registry. And so I wanted to, have a couple closing remarks, but first, another special thank you to Dr. Shannon Elf for sharing her time and her collaborators' work with us today, because we wanted you all as donors to know that the groundbreaking work, your contributions are directly making possible today and into the future, and really get to know the innovative scientists who are working so hard to crack the many, many codes of MPNs. And so we're grateful for that and look forward to sharing the outcomes of this CRISPR work, hopefully over the next year to come. And I have to acknowledge, going into our board of directors slide, for you all to see that the leadership of the MPN Research Foundation's board of directors, you've heard directly today from Barbara and Brandon, the course that was charted 25 years ago, that gives us the confidence that we can have these ambitious and optimistic goals of finding the answers to MPN disease progression, as Brandon shared, potentially even within the next maybe few years or a decade. And so I'm incredibly fortunate to have this visionary board, a steady board of directors who they continue to show their trust in our mission, in our team and the research that we fund. They show that trust with their own dollars. And this Giving Tuesday, I'm really humbled to share that the board of directors has collectively pledged nearly $150,000 of their own funding towards our annual fundraising goal this year. So we are incredibly grateful for that. And as generous and as full of insight and hope as that is to have that support from our board of directors, as you've heard today, and you all well know as patients and caregivers and family members and friends of patients living with an MPN, you know that our work is never done. There is always more promising work. As Brandon mentioned, we leave a lot on the table every time we go out to fund. There are projects that we could support and move faster if we had more funding. And so today I'm challenging all of you, our donors, our community that has made this all possible. I am challenging you to be inspired by our board of directors, and let us see how far we can go in 2026 with your continued support, your continued trust, and your continued funding as we keep pushing towards cures. Really, our goal is cures, and we think that's possible for ET, PV, and MF. So we thank you for your contributions that you have already made this year. And we ask you to consider using this link on the slide here or the QR code to help us close our year strong. We thank you for your engagement today. And as promised, we will follow up and respond to your very thoughtful questions and your chats. And we're always here for you. And so please don't hesitate to reach out to the staff, to our emails on our website to learn more about the work that we're doing, because it really is having an impact. Everything that you all are doing for us as an organization is having an impact. And so with that, from all of us at MPN Research Foundation, the staff, our board of directors, On behalf of the patients we serve and the scientists that we fund, we're wishing you a peaceful holiday season and an inspired new year to come. Thank you.